Welcome back to Corduroy, the Heart of Clinical Care. I'm your host, Dr. Roy Ziegelstein. I'm thrilled to have Dr. Lisa Rosenbaum on today's show. She brings her experience as a cardiologist and national correspondent for the New England Journal of Medicine to an insightful conversation on trust between patient and clinician and the role technology will have at the point of care. Before we introduce Dr. Rosenbaum, we'll explore recent policy shifts in healthcare and dive into some new research of interest. I'd like to kick us off with a segment titled Policy Pulse, where I'll share federal policy proposals, rules and regulations or guidelines from reputable associations so you have a better grasp on how your world might be impacted. You know, when I was a boy, my father drove a Corvair. Let's just say it had a lot of problems. But one thing I wasn't aware of, it wasn't safe. Ralph Nader's book, Unsafe at Any Speed, highlighted the Corvair's faulty rear suspension system that could cause it to roll over. Thankfully, we never had any problem like that in my family. However, the book and Nader's work really highlighted the importance of safety in the auto industry and consumer protection, really like nothing ever before had. And it turns out that we may now be in a critical phase in healthcare AI, and we may have a few documents that will help protect patients and the public health. First, the Coalition for Health AI's recently released AI Governance Playbook, which offers health systems a practical roadmap for implementing AI safety, transparency, and consistency, and also the Joint Commission's responsible use of AI in healthcare certification. I recommend that listeners take a glance at the relevant information about these initiatives, but the bottom line is that there's greater emphasis than ever now on how evidence must include validation, workflow fit, safety monitoring, bias assessment, transparency, and real-world performance. It's clear that human oversight is critical to safeguard patient safety and care delivery. That should do it for today's Policy Pulse. But as always, if something catches your eye, please reach out and let me know on LinkedIn. Now let's move on to our next segment, recapping the research. As a cardiologist, I teach students and residents about the treatment of heart disease all the time. When I tell them about the use of SGLT2 inhibitors, a class of medications used to treat diabetes, to treat heart failure, they often ask how it came to be that a drug for diabetes was found to benefit patients with heart failure. And I tell them, it turns out that in 2007, a paper published in the New England Journal of Medicine reported that a medication used to treat diabetes, Rosiglitazone, also called Avandia, unexpectedly increased the risk of myocardial infarction or heart attack and death from heart disease. And based on that surprising finding, the FDA ruled that drug companies wanting to bring a new diabetes drug to market had to not only study its effect on diabetes, but on cardiovascular outcomes as well. So, when drug companies wanted to bring SGLT2 inhibitors to market to treat diabetes, they had to also study cardiovascular endpoints to make sure that the drugs didn't unexpectedly result in harm. Quite the opposite. These drugs not only didn't increase cardiovascular risk, they actually helped patients with heart failure. So the question is, what does this have to do with recent research? Well, a poster presented at the American Society of Clinical Oncology has been making headlines recently because it reported that the use of GLP-1 receptor agonists, those drugs that are in the news all the time nowadays, was associated with a decreased risk of cancer progression. Now, we have to be careful. It was a poster, so it hasn't been subjected to the typical process of peer review, and it's an association, not evidence from a randomized placebo-controlled trial. But let's talk about the research for a minute. The authors studied over 10,000 people with stage 1 to 3 cancer, so earlier stages of cancer, who started GLP-1 receptor agonists after diagnosis of cancer, and then propensity matched them to patients treated with a different class of medications for diabetes. Now, let me just explain for a moment what propensity matching is. Propensity score matching tries to do what randomization does, but without randomization. It matches treated and untreated groups based on certain characteristics that are related to the likelihood of receiving the treatment in question. In this case, demographics, BMI, glycemic factors, smoking, other illnesses and medications, among other factors. But what propensity score matching can't do is match groups based on factors not considered. And those factors could influence the outcome of interest. In any case, in this poster presentation, exposure to GLP-1 receptor agonists was associated with reduced metastatic progression in 6 of 7 different types of cancers studied, most notably breast cancer. Interestingly, the investigators looked at GLP-1 receptor expression, so the expression of GLP-1 receptors actually on the tumors themselves, and found that high tumor GLP-1 receptor expression correlated with improved survival. So while not a randomized controlled trial, this is really provocative, especially given the widespread use of GLP-1 drugs and the fact that previous papers had suggested a similar phenomenon. I also wanted to make sure that listeners heard about another recent study that might address the age-old question: can someone who seems to not be paying attention, or perhaps who seems to have fallen asleep in a meeting, be aware of anything going on around them? I mean, after all, we've all seen people who seem to fall asleep in meetings. Maybe even we've seen them on the news or on television. So the question is, what's going on with those people? And even more so, can our brains continue to process sensory input even when we are unconscious? A paper published in one of the world's leading scientific journals, Nature, studied this very question. They found that the human brain is able to process language and sounds while in an unconscious state under general anesthesia. Samir Sheth, professor of neurosurgery at Baylor College of Medicine and the senior author of the study, noted, quote, "Our findings show that the brain is far more active and capable during unconsciousness than previously thought. Even when patients are fully anesthetized, their brains continue to analyze the world around them." I'm not sure I have much of a reaction to this other than, holy cow. I mean, this really makes me wonder about the line between consciousness and unconsciousness. It makes me think differently about the times I've seen people in a coma who seem not to interact with their environment at all and then tap their foot or seem to wake up when music is played around them. Just to share a story that I think might be related, I remember many years ago, about almost 12 years ago now, my mother was working in a nursing home as a volunteer in recreation therapy. And she asked the recreation therapist whether her grandson, my son, might be able to come and play guitar for some of the residents in the nursing home. And of course, the recreation therapist said yes. And of course, when my mother asked my son to do this, he immediately said yes. And so he came in to the nursing home. He sat in the middle of a circle. The residents were put all around him to listen to him play guitar and sing. And he did. There was one resident who really had been unresponsive and only able to eat when food was put on a spoon or a fork in front of her. but had not responded to any of the nursing home personnel really for years. And I watched as my son played guitar and sang. I watched and I saw her foot tapping to the music. And I said to the recreation therapist, "Do you see that?" It was really quite amazing to watch and really showed me that even in someone who seems to be unconscious, it turns out that there's part of the brain that is responding to stimuli around us. And so I think this study really made me think of that experience that I really couldn't explain before now. You should have a look at the article in Nature. I'd love to hear your thoughts. And perhaps think about that study the next time you see someone who seems to be sound asleep during a meeting. And now, my interview with Dr. Lisa Rosenbaum. It's really an absolute pleasure to welcome Lisa Rosenbaum to the podcast today. Lisa is a cardiologist at Harvard Medical School and a national correspondent for the New England Journal of Medicine, where she's a regularly featured author and also hosts a podcast of her own called Not Otherwise Specified. So she is very comfortable with podcasting. I know Lisa won't like that I'm saying this, but she is, simply put, one of the most influential figures in medicine today, largely because of her writings and podcasts. So it's really a thrill for me to welcome Lisa today. We're going to be focusing on three things today. The first is trust and also how that relates to patient vulnerability. The second is primary care, which Lisa writes a lot about. And the third is technology and AI in clinical decision support. First, Lisa, could you maybe introduce yourself a little more and tell us how you got in medicine, period?
Yes. Well, first, thank you so much for having me. It's such an honor, and thank you for that lovely introduction. How I got into medicine. I am the daughter of two physicians and the granddaughter of a physician and the niece of several physicians. And I think that when I was growing up, it became pretty obvious to me very early on that being a doctor was an exceptionally gratifying, meaningful way to live. It wasn't a job for my parents or my grandfather. It really was a way of life. And I grew up in Portland, Oregon, which, it's not a small town, but it's definitely not a big town. And so I think I'd go all over with my parents as well. And I spent a lot of time with my grandfather, and, we'd run into patients of theirs, and my mother's a cardiologist, and, people would tell me she saved their lives. And as a child, that is awe-inspiring. It's still awe-inspiring to me. And so I think I always knew I wanted to be a doctor. I think the writing was the part that was surprising.
That's great. That's I'm sure it's helpful for people to hear where you came from. So I want to talk about trust for a minute. Every time we get on an airplane, right, we have to trust. Now there's self-driving cars, which still frighten me, to tell you the truth. But you've written a lot about trust in medicine. Why do people trust anyone or anything? And why do they trust doctors in particular?
Well, part of why I've been writing about it is I think people are starting to trust doctors less. But I think that, trust is on one hand the most interesting topic of our time, and also the most complicated. And so I think, there are lots of reasons why people trust or don't trust. I think that trust comes from relationships. I think that people trust doctors when they feel like those doctors care about them, when they feel like those doctors have their best interests at heart, when they sense that the doctor isn't just trying to get through a bunch of, check boxes and then running away. And so I think that's part of what engenders trust. I think that, people obviously the changes in our information landscape have also complicated what creates trust between patients and doctors. And so I think that when people come to a physician with information that they've gotten, whether it's from ChatGPT or from TikTok, I think that they're more likely to trust a doctor who takes that information seriously, even if the doctor doesn't agree with it. And I think that's where a lot of us get hung up, because I think we feel obligated to say, no, that is wrong. And I think that people feel dismissed by us a lot of the time when we do that. And I think that's part of what's been so challenging for a lot of people who come in with information that may not be correct, at least, according to the way we've been trained.
Yeah, thanks. I think that's an important perspective. So I have a question about trust as it relates to vulnerability. In part of your article, which was a great article, by the way, is a long-simmering crisis boiling over U.S. primary care today. In that article, you have this discussion between Joe Rogan and Mark Zuckerberg, in which Joe Rogan says to Mark Zuckerberg that he shouldn't follow his physician's advice because, quote, there's other people to talk to. And then you note, here's the quote, sick people are simply more beholden to physicians' advice. Do you think that, I've been thinking a lot about this because, I have a primary care physician and I trust my primary care physician. And I wondered, do you think that patients' trust in clinicians is dependent on their vulnerability, on maybe even lack of power or agency?
I do think that is a factor. I mean, one thing that I've noticed in my own practice, and I practice cardiology in a big hospital, is that it's very rare for me when somebody is really sick and they know they're really sick to have them disagree with what I recommend. For better or worse, I think it does create a sense of vulnerability, if not desperation. And so in those moments, people are less inclined to look to TikTok or Twitter or YouTube, wherever it is, for advice, because they know that their lives are at stake. And that doesn't mean they should be more trusting of us in those moments, but I definitely encounter far less friction in those moments than I do. For instance, if somebody's having an osteal elevation MI and STEMI and I say, I think you need a cath, rarely do they say no. Whereas if 2 days later I'm like, you're going to need to take a statin for life, that is a conversation. And you meet a lot more skepticism. And I think part of it is the sense of vulnerability, and part of it is chronicity, and then part of it is just the things in our culture that we have decided to be skeptical of. I think statins are really interesting because I think that we did so much public education around cardiovascular health in terms of behaviors that promote cardiovascular health. And so when somebody's had an MI and then you tell them they have to take all their medications, there's a lot of shame I encounter. And so I think when you tell people they have to take these medications, there's almost sometimes a feeling like, I did this to myself and now I need to undo it myself. So that's all to say these people's reluctance in acute versus chronic decisions is also complex and depends on the person and what is being advised. But I do think that when people are more vulnerable, which sounds kind of counterintuitive, they're more trusting.
I actually don't think it's counterintuitive. In fact, as I said, it's kind of made me wonder about my own emotional or mental state when I'm at the doctor. So it is kind of interesting. So your comments about cath and statins resonate with me since, like you, I'm a cardiologist at a large hospital. And also, like you, I'm a cardiologist interested in primary care. So why do you have this interest in primary care? Where did that come from? And what is that about?
Well, obviously I love cardiology as a clinician, but in this other life I have as a writer and a podcaster, I love the profession. Like, the profession is so dear to me. So anything that I can do in my work to help the profession is sort of like my North Star. That's how I think about what to write. And what I started noticing, first I started noticing a lot of people who I cared about, who I really admired, were leaving for concierge practices. And, I think when I first learned of concierge medicine, I thought it was sort of like for wealthy, worried, well people, looking for benzos, essentially. That's how I thought of it in my brain. And suddenly, like, some of the best doctors I knew were doing it. And that really seemed like a cultural change. And then at the same time, all of a sudden, well, I actually happened to switch insurers, but people often, how this happens all the time. Like, people send you a text and they're like, can you help me find a primary care doc? And all of a sudden, I was like, absolutely not. No, 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 no. Like, no, you have to do concierge. You can't get in anywhere. And so if people who are connected can't get primary care doctors, like, what does that mean for those who are more marginalized? Like, it just seemed like, you read the title of the first essay, like, primary care, we all know, has been struggling for a while, but it did seem to have reached some sort of tipping point to me. And that felt really important. And I guess again, my grandfather was a rheumatologist, but at the time, you know, specialists practiced a lot of internal medicine. So I sort of grew up with this idea of the consummate internist, the person who rounds on the weekends on their inpatients and makes home visits. And I might be making that up that he made home visits, but I don't think I am. But possibly you should fact check me. And is part of a community. And it felt like that model of physicianhood was becoming obsolete. And it didn't feel to me like it had to become obsolete because everybody else had developed such hyper specialized expertise. There are some changes in medicine that you sort of have to say, okay, that's just how it is. Like, we can do all these cool things. So therefore the generalist, doesn't have a place anymore. And I don't believe that for 1 second. And in fact, if anything, as I looked around at society, and this is another reason that I was thinking a lot about primary care, the things we were talking about, loneliness, the erosion of relationships, people's social isolation, all of those things seem to me to be like counteracted with like the idealized version of primary care where you have a long-standing relationship with someone who cares about you. And so it felt really important to me culturally as well. And then that introduced this question of, if it's so important culturally and I think still to medicine, why is it so undervalued? And can that change?
Yeah, it makes a lot. I think that makes a lot of sense, certainly to me. So it's a kind of a segue to the last part, which is technology. And I'm not. Don't worry, I'm not going to ask you a technical question and so forth. But rather, I think we both know that technology is becoming much more of a part of our interaction with patients. I mean, for many years now, I myself have used a point of care ultrasound, for example, which, from my perspective, contrary to what people believed in the beginning, I think it brings me closer to patients. AI now is really becoming part of the clinician patient or patient clinician relationship. It is literally in the room at some times in terms of an AI scribe or ambient AI. One of the things that when you've talked about AI recently, in fact, the title of that podcast was "Can AI Solve Primary Care?" Which is, for those people who've not listened, they should listen. But the question is, in that podcast, you don't talk a lot about AI in clinical decision support. Do you think that will be helpful? I shouldn't even use the future tense. Do you think that it is helpful? Does it get in the way of patients and clinicians? Does it bring them closer together? Does it make for better medicine?
I think the most honest answer is I don't know, but I will tell you what I think. It's nice to have a source of trusted knowledge. It's forced me to learn how to vet a little bit some of the answers. You can't just implicitly trust it. So I think just if you isolate the physician kind of access to data and resources, I really think it's a good thing. When you start to think about, okay, is AI going to be baked into our workflows as a clinical tool decision support to tell us what to do? Then the question becomes, well, what values will the AI have? Is it my values? Is it the values that, I assumed when I, took the Hippocratic Oath? Or is it the values of my corporate overlords? Or is it the patient's values? So that gets really complicated. And I think that none of us know what that's going to look like. But I think there's reason to be concerned given how so many of us already feel like our values have been a little bit compromised by the corporatization of medicine. And then I think there's this sort of question around what will it look like between doctor and patient. And this gets back to all the questions around trust and sort of the tensions when somebody has a different source of information. So I think like anything, this will just depend on the person, the doctor, and the questions being asked. But, if somebody comes in to you and they have a swollen knee, for instance, and they say, I'm just completely making this up, but like ChatGPT says you need to like tap my knee because I might have septic arthritis. And you look at the knee and you're like, you absolutely don't have septic arthritis. And then there's how much time do you spend then trying to persuade them that ChatGPT is wrong? Or what if you're wrong? And it turns out that a lot of the time, because some of the studies, I think, when you do the physician in the loop studies, we're already learning like sometimes maybe AI is better than us. And, that's really existentially frightening. But I think, there are just infinite questions. Like I just gave one scenario with one person and one doctor, and we don't know how that will play out. And so I'm not an AI evangelist, but I'm not as scared about AI, I think, as a lot of people, and especially when it comes to medicine. Like, I don't think doctors are going to be replaced. I think humans need other humans. I think we are made to like connect to one another. And I just don't see that changing, particularly given the vulnerability of being ill that is just kind of never going to change. And I think that there are a lot of places where if AI can automate things that are already burdening us, it'll be super helpful. And I think the question you raise is the most important one, like clinical decision support. Is it going to help? Is it going to hurt? How will we know? How will we regulate it? Are we going to study every possible scenario? No, that's not going to happen. Like, do we need a different type of regulatory body that's not the FDA? I mean, there are so many interesting questions. I'm personally, because I'm intellectually interested and curious, like for me, in a very selfish way, AI is exciting because it gives me a lot to think about.
Right. And yeah, I can totally understand that. Well, I want to thank you for being a guest on the podcast. Thank you for really shining a light on so many of the important issues in medicine today. And today for talking about trust, primary care, and technology. Thank you, Lisa, so much.
Thank you so much for having me.
That's all we have time for today, so thank you for listening in. Lisa, thank you so much for joining me today and for your perspectives on trust in today's doctor's office. Please stay tuned for more episodes, which will be released the first Tuesday of every month. Like and subscribe to be notified of new episodes, and please connect with me on LinkedIn. I'd love to hear from you. Until next time, stay true to the core.